Hello, everybody. Thank you for attending today's educational webinar on CSF, cerebrospinal fluid leaks, and Marfan syndrome and related conditions. My name is Stacy Watson, and I am the director of the Loeys-Dietz syndrome division of the Marfan Foundation. And I'm joined tonight by my colleague, Helene Brooke. We and our speaker, Dr. Ian Carroll, who I'll speak more about momentarily. So we are recording this webinar and posting it on our YouTube channel, where you will find many other informative videos and webinar recordings. Please use the Q&A feature to ask any questions you may have so they don't get lost in conversations in the chat. Please join me in welcoming Dr. Ian Carroll for today's webinar. Dr. Carroll is an associate professor of anesthesiology, perioperative, and pain medicine, and chief of the Stanford CSF leak headache program at Stanford University School of Medicine. He founded the Stanford CSF leak headache program in 2015 after his daughter's experience with an undiagnosed CSF leak, fueling his dedication to helping patients with this condition. A summa cum laude graduate of Columbia University, he completed his MD residency and fellowship at Stanford, where he also earned an MS in clinical epidemiology. Dr. Carroll has published extensively and is active in training Stanford residents and fellows in anesthesia, pain management, and neurology, and we are honored to learn from him today.
Thank you.
Do you want me to take this slide off? Or do you want to keep it
No,
up? Or do you...
I think I need you to do that in order to share, but I will start.
All right, here we go.
So it says that it's sending a request to you for me to share my screen. Right. This. All right, so you guys see my all right, it's good. So we're going to talk about CSF leaks, which is my passion. I don't hold myself out to be any particular expert when it comes to Marfan, but this one little area that can touch the lives of patients with Marfan is a passion and mission of mine. And we'll talk a little bit about what a CSF leak is, how it happens, what we've learned about it, and hopefully give you, the community, some tools for dealing with this. I don't have any conflicts. The work you'll see here is supported by a gift made by a grateful family to Stanford to help support my work. So with that, I'll start by telling you that CSF, cerebrospinal fluid, is contained by a watertight bag that is made of connective tissue called dura. And that dura can be genetically weak and can, like every other connective tissue in the body, rupture even in response to relatively normal strain of daily living. So just in the same way that you can tear your cartilage in your knee just from daily living, you can tear your dura just from doing the stuff that we all do in life. And beyond that, it can also be torn by trauma. It can be punctured by sharp edges, bone spurs that can happen, needles, scalpels, screws, all of which can affect people in the Marfan community. So people with Marfan will often have scoliosis. They're more likely to have surgery. When they have surgery, they're putting screws in there. If the screw isn't quite exactly put in the right place, it can get into the dura. When you're having back surgery, a scalpel in the wrong place can penetrate that dura. Needles for epidural steroid injections or lumbar punctures, or many people in the Marfan community have aortic surgery, and often to help preserve the function of the spinal cord during aortic surgery, the neurosurgery team, or excuse me, the thoracic surgery team will place something called a lumbar drain, which is a drain that they deliberately put inside that bag of fluid, using a pretty big needle to puncture that bag of fluid and put the drain in there. And by reducing the spinal fluid pressure during the operation, that can help the spinal cord itself be better perfused by blood, and help improve the circulation of blood in the spinal cord and help protect it. But at the end of that surgery, by the end of that hospitalization, when they take that lumbar drain out, it can leave the dura with a little hole or an area of weakness. And I think that often gets overlooked in patients undergoing that surgery. And so, the dura of patients with Marfan is at risk both because of the um, the the disorder of connective tissue um, that's there, and also because of the higher risk of undergoing procedures that put that dura in danger and at risk. So that CSF is there to provide some degree of buoyancy to the brain. The brain is mostly fat, and in the same way that olive oil will float on top of water, the brain is essentially buoyant in the CSF, and we are all basically having our brains floating in this bag of fluid that we are carrying around. Like it's almost like a bad science fiction movie where the brains are just floating there in the water. And when the bag is intact, it contains fluid that reduces the weight of the brain 96% and prevents the brain from trying to sag and descend out the bottom of the skull under the influence of gravity. It just floats there. And so when there's not enough fluid, the brain itself can get distorted and it doesn't function quite right, and it can cause all kinds of problems. Patients with Marfan, not only do they have focal areas of weakness, but they can have essentially the same kind of aneurysmal dilation of the dura, the same kind of aneurysmal dilation that happens to the aorta, where it expands and thins under pressure. That can happen to the bag of fluid, and you'll see that here where the bag of fluid in the lumbar spine has become distended and widened. And it's interesting, the bones are designed to essentially give way to the bag of fluid as it expands. And so the expansion of the bag down here in the sacrum will actually kind of erode the bones of the sacrum, weakening those. Um, and this is just one of the things that can happen to make the dura even weaker in patients with Marfan. Um, in addition to this dural ectasia, this general widening, patients with Marfan will often have extensive what are called perineural cysts, which I'll show you another picture of. These aren't really cysts, but essentially smaller aneurysms of the bag at the levels where the nerve roots come out. So here you see a CT myelogram of the upper, um, in the neck, essentially, or excuse me, in the thoracic spine. And you've got the spinal cord here. The white stuff is spinal fluid around it. And you have these little kind of aneurysmal balloonings where the nerve root comes out. You can see a larger picture of it here on the right, where these little aneurysmal outpouchings of the bag can happen. And these are areas where the dura itself can become weaker and give rise to a leak. So what are the symptoms of a CSF leak? When this happens, um, the most obvious symptom and the one that doctors are most plugged into is headache. And it's often expressed as a sense of head pressure, often on both sides of the midline. It can affect the back of the head and the base of the head a little more than the rest of the head, but really you can feel it in all parts of the head, and sometimes it can be on just one side. One of the core features with spinal fluid leaks, especially when the spinal fluid leak is new, is that this head pain may be much better when someone is laying down and much worse when someone has been upright, and especially true after the passage of time. So, because most of us are flat for 8 hours when we sleep at night, often patients with a CSF leak will feel their best when they first open their eyes in the morning before they even get up to go to the bathroom. And then at some point after they get upright and they start their day, sometimes when they're going to the bathroom, sometimes a half hour later when they're having their coffee, they'll start to feel that head pressure come on. Sometimes it'll even take until the later part of the day, and they'll get what we call a second half of the day headache because they have to be upright for longer before they become symptomatic. It's clear that as leaks persist, as the duration of a leak gets longer, the likelihood that it will have an obvious postural component goes down. And it now, as somebody has their leak for longer, it can take sometimes extended periods of time flat for them to feel better. And sometimes head pain won't go away when they're flat. Um, and this often leads to misdiagnosis, as many doctors think incorrectly that if your head pain doesn't get better in 15 minutes when you're lying flat, then you can't have a leak. Or if your head pain isn't worse within 15 minutes of getting upright, you can't have a leak. And that's just not really true. And most doctors will be very familiar with the syndrome of a CSF leak after a needle has punctured the dura, what's called a post-dural puncture headache. But while almost every doctor knows about that, many doctors don't realize that you can have the same kind of problem spontaneously without any kind of clear precipitating event that they are used to seeing in people who've had a lumbar puncture, for instance, to rule out meningitis in the ER. So the headache is a ubiquitous symptom. Almost all patients have it. In many, it is postural, but not in all. And the absence of the postural component often leads to misdiagnosis. In addition, other symptoms include profound fatigue, uh, lots of neck pain and stiffness, nausea and vomiting. I had one patient who um, the first clue that um, she had a CSF leak was when she said to me, I consulted about some other problems she had, and she said, you know, if only you could help me with my chronic nausea. And I said, what do you mean your nausea? And she said, well, for the last year, I've been vomiting 6 to 9 times a day, and I've lost 60 pounds. So sometimes that nausea and vomiting can really be profound. The CSF uh, communicates and is connected to the inner ear fluid, the perilymph. And so disorders of CSF pressure will often affect the functions of the inner ear, giving rise to changes in how normal sounds sound to you, giving rise to ringing in the ears, giving rise to changes in balance and a sense of imbalance or vertigo. And then many patients with CSF leak have symptoms that are referable to their brain really experiencing an impairment of function. They'll have difficulty with memory, difficulty with concentration. Often it'll be non-focal neurologic symptoms that really make it hard for us to know exactly what's going on. I had a patient tell me um, that she was driving home from where she brought her daughter to ballet, and she'd bring her daughter there, 3 times a week for years. And then one day she's driving home and she's on the highway, and suddenly she doesn't know where she is or what exit she's supposed to take to get home. Just, just a kind of spatial disorientation. So the symptoms of a CSF leak really go beyond just head pain, and they really can affect multiple different aspects of life. So one of the things that I wanted to kind of share with you was how to overcome resistance maybe from the medical community from looking at the possibility of a CSF leak, something that your doctors may either not be very familiar with or alternatively may think that they understand but really don't. Um, so one of the things you can do is really document the symptoms of a CSF leak. So this QR code in the lower right-hand corner is a link that I provide to a Google Drive folder that I share. And in that folder, not only are there a group of articles about different aspects of CSF leak, but there's something that we call our 48-hour flat test. This is a test that we designed to help quantify the extent to which somebody has the symptoms of a CSF leak and the extent to which those symptoms improve when you get flat. So with this test, somebody will, on typically a Friday night after being up all day, they will rate the core symptoms of a CSF leak from 0 to 10, where 0 is no symptom, 10 is severe symptoms, and they will rate symptoms including head pain, neck pain, nausea, fatigue, ringing in the ears, and difficulty with memory and concentration. Each of those symptoms, their severity from 0 to 10. And then when they go to sleep on Friday night, when they wake up on Saturday, they go to the bathroom and get right back to being in bed and staying flat all day Saturday and again all day Sunday, so that they can see if their typical, for instance, late afternoon headache gets better if they spend the whole day flat. And so after spending essentially 48 hours flat, on Sunday, they rate all of those symptoms again. And then they get upright and they kind of, patter around the house for a couple hours, not being too active, but upright. And then they rate all of those symptoms yet a third time to see if, in fact, do the symptoms get markedly better when flat, and do they then come back when upright again? Because really, a CSF leak is the best, most well understood cause of severe postural headache. So, to the extent that you have those symptoms, it's important to document how severe they are and to what extent they're postural. So, the 48-hour flat test can help with that. And we also include a Google Doc in that folder that is a review of symptoms related to CSF leak, so that you can go through that with your doctor and say, look, I have this symptom, I have this symptom, I have this symptom. And it can start to establish that there really is something there. Help your doctor understand that Marfan and other hereditary disorders of connective tissue are and in fact, the best known risk factor for developing a CSF leak in the absence of a severe trauma. So we know that that Marfan is associated with spontaneous CSF leaks, other hereditary disorders of connective tissue, including Ehlers-Danlos, polycystic kidney disease, neurofibromatosis, are also associated with it. And indeed, even in people who lack one of those specific diagnoses, but who have the clinical stigmata of those diagnoses, are more likely to have a CSF leak. So for instance, when you evaluate people with CSF leaks, you will find a higher incidence of benign joint hyperlaxity than among a randomly selected group of healthy controls. And when you start to ask them questions, you will often find, even if they don't have Marfan or Ehlers-Danlos as a formal diagnosis, that they'll have, unusual skin scars, really thin or broad-based, or they'll have a history of multiple joint dislocations. Um, and and so even in those people who don't carry the diagnosis of Marfan, but have the stigmata of other connective tissue abnormalities, we think that those people are more likely to have a CSF leak as well. We have to help educate your doctors that CSF leaks are not rare. I've had a lot of patients tell me their doctors wouldn't take them seriously because they were told um, that it was too rare for it to be what was happening to them. This paper, published by one of my colleagues, Dr. Shivink, who is one of the reigning world experts on CSF leaks, a neurosurgeon at Cedars-Sinai in LA, he did something interesting, which is he went and reviewed with his colleagues the MRIs of the brain of everybody who walked in off the street at Cedars-Sinai's emergency room complaining of headache. And they identified over a 2-year period all of the people whose MRIs of the brain actually showed changes that suggested CSF leak. All of those people had their leaks subsequently confirmed with a test called a CT myelogram. And at the same time, they counted up the number of people who walked in with an unrelated problem that also causes headache called a subarachnoid hemorrhage. Now, we know how frequently subarachnoid hemorrhages are, and so they thought if they could figure out the relative frequency of CSF leaks to the subarachnoid hemorrhages, they'd be able to come up with an estimate of just how frequent these CSF leaks are. And what they found in their 2-year follow-up was they counted up 22 cases of subarachnoid hemorrhage and 11 cases of spontaneous CSF leaks. Now, we know that subarachnoid hemorrhages, aneurysmal subarachnoid hemorrhages, have a incidence, of about 10 per 100,000 per year. And so they estimated that that the frequency of spontaneous CSF leaks was about half of that, because there had been 11 cases of CSF leak compared to the 22 cases of subarachnoid hemorrhage. So they estimated that the incidence of CSF leak was about 5 per 100,000, which puts it right in the category of things that are commonly filling your local academic hospital. Esophageal cancer is about 4 per 100,000. Pancreatic cancer is about 5 per 100,000. Suicide is about 13 per 100,000. So a CSF leak should be happening and presenting to those medical centers, more or less with the same frequency as these other related problems, which we are never surprised to find somebody with in the hospital. A lion carrying a crocodile is rare, but a CSF leak walking into the hospital is not. Helping your doctor understand why you may be at elevated risk is important. If your headache started following spine surgery, which is not uncommon in people with hereditary disorders of connective tissue. If your headache started following a whiplash-like trauma, that's a known risk factor. If you had a known or suspected dural puncture, even if you were patched, that's a known risk factor. So this can mean a diagnostic lumbar puncture, what's called a spinal tap, often happens to us as kids. If someone's trying to rule out meningitis, that's what happened to my daughter. An accidental dural puncture can happen during an epidural, for instance, for a labor epidural. 1 to 2% of the time they accidentally go too far and they put that needle into the dura. And epidural injections for things like steroids. So the things that can cause people to leak, whiplash accidents, having abnormal hereditary disorders of connective tissue. This was one of the first people I saw. And that's a picture of her bending her wrist back and touching her thumb to her forearm as she crosses each finger over the finger next to it. Down here, I'm showing one of, again, my early patients who had a little bone spur coming off of a degenerative disc. And if your connective tissue isn't right, you're going to have more than your share of degenerative discs, and the likelihood that one of them may calcify is going to be a little higher. And if you have a calcified disc that's sharp like that, it can just penetrate through the front of the bag there. So we know those are things that can cause people to leak. Second. No, wanted. My computer must have really wanted to make that point. All right, so we talked about how a known dural puncture can cause a CSF leak. These are studies of chronic headache after unintended dural punctures with labor epidurals. And what I'm showing you here in orange is the control rate of having long-term headaches if you had an epidural that didn't accidentally penetrate the dura. Okay, that's the orange columns. The blue columns next to it is the rate of new chronic long-term headaches if you had an accidental puncture of the dura when having that labor epidural. And so what you see is these unintended dural punctures that people have in study after study causes a non-trivial rate of chronic new headaches, presumably related to CSF leaks. This is what the dura looks like in a patient that had a remote dural puncture. So this patient was a physician who had an unusual problem where she bled in her brain, and they treated her. And as part of her treatment, they put in one of those lumbar drains I told you about they often use for aortic surgery. And she totally survived the bleed in her brain, but afterwards was left with these debilitating headaches that were worsened whenever she got upright. And because of the data I just showed you, kind of emphasizing the likelihood of having a chronic leak after a puncture, we went looking for her leak in her lumbar spine where the lumbar drain had been. And that little hole there is where the drain had gone in. And if you look at that, it's nice and round, and the edges are well healed. There's no kind of frayed tissue there. That is a healed hole. The hole is healed. The edges are healed with it in an open conformation. That thing is not trying to heal any further at all. It thinks that it has healed the injury there. And so that was never going to seal itself, nor was it going to ever be sealed with a blood patch injecting blood over it. It had to be found and sewn shut. Yeah, so that's what it looks like after being sewn shut. Here's a picture of another post-puncture problem that can happen with the dura. The one I just showed you, this one is basically a fistula. It's a healed open hole in a piece of connective tissue, basically invisible on an MRI. This, at least, was somewhat visible to careful inspection of the MRI, where this is the dura again, and this is where somebody's labor epidural had penetrated through the dura and left it when it healed with this flimsy pimple-like ball protruding through the defect in the outer dura. And this was causing somebody to leak for 12 years. And then had to be fixed in about a 30-minute surgery by having it sewn shut. These 4 different studies have looked at the rate at which those patients will have positive imaging, i.e., the rate at which people with those kinds of problems, chronic new CSF leak headaches that started at the time of a known dural puncture, what percentage of them had positive signs of a CSF leak when they looked at their brain MRI, and that's what their data look like. All right, so the big blue column over here on the right is our fantasy that MRI brains are good at detecting CSF leaks. But in fact, in the 4 studies that have looked at this, in no study was the rate of a positive brain MRI higher than 10%, and in some of them it was 0. So it's probably true that for some kinds of CSF leaks, at least the kinds that are caused by punctures, that MRIs of the brain are not particularly sensitive. Now, not every CSF leak is caused by a trauma or a needle in someone's hand. This is a study, again, by Dr. Shivink, where he interviewed 80 patients who had spontaneous CSF leaks. That was not in the setting of being after surgery or after a puncture. And he asked them if they were able to identify what they were doing that started their leak. And 2/3 of the patients couldn't identify anything. They were just having a normal day. But a third of the patients could say what they were doing when their headaches started. And there were some recurring themes over and over again. So you see here, one person's yoga stretching, yoga pulling their head up. Some others were talking about Pilates. So So yoga, stretching, or Pilates seems to be an inciting event for some people. For many people, it was bending over to pick up something heavy. And for another group of people, it was generating pressure in their abdomen or chest. Um, weightlifting or straining when constipated or when vomiting or when coughing, generating that kind of pressure in their abdomen or chest. So, but the thing I think that is maybe important for your doctors to know is 2/3 of these patients couldn't say they were doing anything when their leak started. So, when I was in training, I was trained that one way to diagnose a CSF leak was to measure something called an opening pressure. And that if somebody had a leak, then the pressure in their spinal fluid would be low. It turns out that that is really not the case. This is data that was gathered by Andy Callan that we wrote up and published together. This was from 17 patients who had imaging proven leaks, a specific kind of leak that I'm going to tell you a little more about in just a few minutes, called a CSF venous fistula, in which the CSF isn't just escaping out of the kind of hole I just showed you, but is actually leaking into a vein, something that we didn't even know existed until 2014. In 17 patients that he identified with that problem, when we looked at opening pressure, slide is again wanting to advance about that. Of the 17 patients, 16 had a normal opening pressure. Those are the ones in red. So, in other words, of the people who had a leak, relying on opening pressure to diagnose and either verify that they had a leak or exclude a leak, it would have miscategorized 16 of the 17 patients and made you think that they did not have a leak when they did. So it would have misdiagnosed 95% of patients. And you can see this is the opening pressures of the patients who had a leak versus those who didn't. They're essentially totally overlapping. This had been previously reported for non-CSF venous fistulas, kind of more typical leaks, by Peter Krantz and the group at Duke, where they looked at 106 patients that had imaging confirmed CSF leaks. And these are the patients who had normal opening pressures, 2/3. So really, we don't think that opening pressure and the dural puncture that has to accomplish opening pressure, putting the needle into that bag of fluid, is really appropriate anymore when a leak is suspected, because it will misidentify people as not having a problem more often than it will correctly identify those that do have the problem. And in fact, in 5% of people with a leak, their opening pressure is actually high when you measure it. So it's a little counterintuitive. So the opening pressure might be useful if low, but a normal opening pressure does not rule out a CSF leak or mean that orthostatic symptoms are due to POTS instead. Both of these brain images are from people who had a leak. On the right is a classic brain MRI finding of somebody with a CSF leak. This is called pachymeningeal enhancement. And you really only see this kind of smooth, diffuse pachymeningeal enhancement, this white covering, wrapping around the outside of the brain. You only really see that in a leak. And because it's so recognizable, it's easy for doctors, neurosurgeons, neurologists, and neuroradiologists to assume that if the pachymeningeal is absent, pachymeningeal enhancement is absent, that means they are not leaking. But in fact, this MRI was also from someone with a leak, and they don't have any pachymeningeal enhancement at all. And it's become clear that actually um, pachymeningeal enhancement often goes away in people who have chronic leaks, which makes those chronic leaks even harder to diagnose, right? So I told you already that the postural nature of the headache with a leak can go away over time. And now I'm telling you that the imaging features go away over time. And I didn't tell you that there's actually data that the opening pressure is more likely to also be normal as the leak persists and becomes chronic. So the longer the leak goes on, whether it's because of their postural symptoms no longer seeming postural, or their pachymeningeal enhancement going away, or their opening pressure starting to be normal, it just gets harder and harder to ever get to the correct diagnosis. This is from a review that talked about how 20% of patients with spontaneous intracranial hypotension, that's the other term for people with a spinal CSF leak, they develop intracranial within the head hypotension, which is supposed to mean low pressure in the head, even though I've just shown you data that the pressure is actually often normal. So it's kind of a misnomer too. And 20% of those patients never develop any of the changes that suggest a CSF leak. Now, I'm going to change gears a little bit and tell you that among people with CSF leaks, as you try to treat them, often the trick to helping them get better is finding where the leak is coming out. And this is especially a problem when the leak is leaking quickly out of the bag, because when the fluid gets out of the bag, it spreads up and down along the outside of the bag. And when you look with an MRI, you just see fluid everywhere and you don't know where it's coming out. And so initially at Mayo Clinic and then later at Cedars, they kind of perfected a technique to try and determine where the leak is among people with a spinal CSF leak called digital subtraction myelography. And with a digital subtraction myelogram, what they do is they inject contrast into the bag of fluid while doing a video x-ray, and they look at the spread of the contrast on the video x-ray. And that's a myelogram. The digital subtraction part of this comes from doing a set of techniques that was originally developed for angiograms, trying to figure out where contrast was spreading in blood vessels. So what they do with a digital subtraction myelogram, and what they had learned from doing angiograms was, if when you're taking this kind of video x-ray, if you digitize the first few frames of the video, and then you subtract everything that remains the same from those first few frames to the later parts of the video, you can get a lot of the structures to disappear. So the bones, they get digitized, and then as the video goes on, they're subtracted out of the remaining images. So the only thing you see on the video is what changes from frame to frame, which is the contrast spreading. Let me show you what that looks like. So here's a digital subtraction myelogram. Let's see if it's going to show it. Okay. Let's see. Nope. Come on, let's try this again. Nope. Well, looks like I'm going to let you down. This, with this kind of study, you would see the contrast kind of spreading along here, and it would be useful in showing where a leak is because it only shows where the contrast spreads. Now, the important thing about this digital subtraction myelogram is that at Cedars-Sinai, when they were doing this hundreds of times, they found just a handful of cases that they reported in this publication in 2014, where when the contrast spread throughout the bag, they saw outside the bag this stuff, a little bit of contrast streaming away in a thin little structure, and they correctly guessed that what was happening here was the contrast was leaking out of the bag into a vein and getting swept away. And this became known as a CSF venous fistula. And the first time I read about this, I thought that's interesting, but it's really hard to diagnose. And even if you're doing this digital subtraction myelography, you hardly ever find it, even among cases of people who clearly have leaks. So how important is this really going to be? Well, when Dr. Shivink showed these images to a neuroradiologist from Toronto named Richard Farb, Dr. Farb looked at these and said, you know what's interesting about these is it looks like these are always coming off the side of the bag where the nerve root is. And so maybe they're doing the test wrong by having people lie face down and injecting the contrast and letting it spread throughout the bag. Maybe what we really want to do is have people lie on their side, and we'll give the contrast in a way that it doesn't mix throughout the bag, but rather pools right along the surface where these little perineural cysts come out, and maybe we'll see them better. And when he started to do that, he found that that really was the case. So Dr. Shivink and Farb teamed up to write this paper. And this is another one of these CSF venous fistulas seen with a conventional digital subtraction myelogram done with someone lying face down. But when they took that same person and they repeated the myelogram with them laying on their side, this fistula, which is pretty subtle here, look like that. Much more prominent, much easier to see. And so in 2018, they reported that if you have patients lie on their side and you do this kind of study, you will find these kinds of CSF venous fistulas much more frequently. And so, they published that right before COVID. And since then, it has become clear that these things that were not known to science until 2014, and that we did not know how to look for effectively until 2018, actually account for half of all the spinal CSF leaks that are out there. This is half the problem. And you will not have that diagnosed with an MRI. You have to inject contrast into the bag with someone lying on their side. And you either do this kind of digital subtraction myelography, or now we know how to do this with someone on a regular CT scanner, but it has to be done with someone lying on their side. And these things are super hard to find and diagnose, but if you get good at doing this kind of imaging technique, you will find a bunch of these in people with leaks. And so those of you who are listening to this, who have had a history of having a CSF leak that could never be found, we now think that half of those that could never be found are probably this kind of fistula coming off of one of the cysts that when we used to look with conventional CT myelography or even prone digital subtraction myelography, we were looking the wrong way. We didn't know how to find them.
Dr.
And
Carroll, I just wanted to give you a quick heads up for that 5-minute warning to move
good,
in. All
good.
right, great.
And so this is what I mostly wanted to kind of get across. Number one, that CSF leaks are common in patients with hereditary disorders of connective tissue. Number two, the ways we historically diagnose this with opening pressure, with MRI brain, with a spine MRI, or even a conventional CT myelography, we've all started to realize that um, those tests often miss the problem. And um, and even in people where you know the CSF leak started with a puncture in the back, most of those people have normal imaging. And so we've come to realize that whether it's an opening pressure or an imaging study, they're often useful when positive to rule in a leak. But when they're negative, we can't just tell someone you're not leaking. It's really hard for us now to be able to tell someone with confidence, we know you are not leaking. And that is the world that you and your doctors now share together. A world of uncertainty where we're having new insights into these problems that have been affecting the Marfan community for years, but only we are now starting to get better at really being able to deliver an effective diagnosis and treatment. And so with that, I will stop sharing. Maybe I'll skip to the folder where I share my shared articles with people. There's a subfolder in there that has all the papers about chronic post-puncture leaks. There's a subfolder in there for those who want to learn more about CSF venous fistulas. The 48-hour flat test is in there. The symptom review is in there. I don't really check that email so much, so you can ignore that. But I do, maybe I do check that sometimes. If you need to reach out to me and be seen at Stanford, it's better for you to email me at ic38@stanford.edu, ic38@stanford.edu. And I can plug you into the normal referral spot. So with that, I'll stop and people can ask questions. Thanks, Stacy.
Hi, all right. So I just want to preface this with if you have very specific questions about your own personal medical history or that of a family member, you can submit them to Dr. Carroll at this email address he sent here. But we also have a really wonderful help center at the foundation. So you can go to marfan.org/ask and submit any kind of non-emergency medical question there and receive a response from one of our team members. They likely consult with our professional advisory board or even specialists like Dr. Carroll. So I wanted to let you know about that. So I tried to consolidate some of these questions into more specific or more broad questions that might answer more than one thing. But there are some questions about blood patches. Are they helpful?
So blood patches are helpful. Um, the it is clear that if a blood patch is done um, soon after a leak starts, it often just stops the leak. Sometimes it takes one, two, three, sometimes more patches, but when done early, um, these are often very effective for leaks and can help you not require surgery. The nice thing about a blood patch is also that um, if you're not sure where the leak is, which often it really is hard to know and to find the leak, a blood patch can still be done and you can put blood in there and try and get it to spread over lots of areas. Sometimes you don't know where the leak is for sure, but you have one or two targets. You got a giant perineural cyst somewhere. You've got an image on a myelogram that looks like maybe it's a CSF venous fistula, but you're not sure. In those patients, you can inject fibrin sealant, which is a kind of patching material, at those spots that you think are likely the leak sites, but you can't say 100% for sure. And because of the lower risk of patching and the lower invasiveness of patching, when you're not sure, it's easier to direct a patch at a target than it is to direct a surgeon at a target, right? hard to get a surgeon to operate on some level that might or might not be the leak, right? Where the imaging is still ambiguous. And one of the things that's been humbling to me about being in this field over time is just how hard it is to know for sure sometimes where the leak is. I mean, the pretty pictures that most of us put in our talks are the ones where the leak is clearly identified, like the one I showed you. But there's a lot of people where, myself and other experts look at the images and say, might be, might not be.
And then
Uh,
are there special considerations when it comes to treatment of CSF leaks for people who have Marfan, Lewy-Dietz syndrome, or, connective tissue conditions? What are some of the things that these community members should go into appointments kind of knowing or being aware of?
I think it's worth having the most experienced person available do the patching for people who have these hereditary disorders of connective tissue. Things like the dural ectasia can really change some of the dynamics of doing the procedure. And, you don't want someone who wants to be helpful um, doing the patch for you when you have Marfan if they haven't really put a needle in very many backs of patients with Marfan, or they're not 100% really confident in that. It's a hard thing because, there's not the centers that do a lot of volume are oversubscribed, and it's hard to get in sometimes. The and I do think it's doing an epidural blood patch on someone who has really significant dural ectasia. It's easy to do that incorrectly, and it's hard. It's hard to give good advice about, they say any port in a storm, and I've seen people with Marfan who had life-threatening CSF leaks who I would hate for them to walk away from this and say, oh, I can't go get a blood patch if I'm in, Michigan because there's not a CSF leak center in Michigan. I think like you need, these things are often severe enough and dangerous enough. You need treatment, but uh, spending some time to get the most experienced person available to do it is worthwhile.
Thank you. Um, some people are just asking if you can give any tips on how to distinguish between a migraine and a CSF leak headache. Are there any distinguishing factors?
Well, I would say people with CSF leaks don't have a lot of good days. They usually have some head discomfort every day to some extent. People who are truly having migraines, there's a subset that progress and transform into daily migraines, chronic migraines, but usually they have some good days. Um, and if you're having daily headaches that have nothing to do with the CSF leak, spending 48 hours flat shouldn't do anything to make that better. If you're having headaches that are really migrainous in nature, staying flat on a Saturday shouldn't make that any better. And that's going to tell you as much as any MRI or invasive test. Like your chronic migraine should not be dramatically better after being flat for 24 or 48 hours and then suddenly much worse again when you're upright for 2 hours. That's a real, for somebody in the Marfan community to find that they really are better when they stay flat, that's a big giant flag that your problem may really be due to a leak.
There's a couple of questions about symptom onset or symptom kind of duration. One person, and you can decide and tell us if these are should be have been lumped in the same category. But how soon after like a spinal surgery or an onset or a puncture would these headaches start to occur? Somebody is explaining in their situation that they had surgery almost 9 years ago, and now they're starting to have some symptoms. Is it possible that it's related to that, or likely that there's something else going on, but it could still be a CSF leak? And then this other person is saying if pain alternatively like resides over time, should they still get diagnosed, or is it possible that that CSF leak has resolved itself? Does that happen?
It's clearly true that some CSF leaks can get better on their own. There's one study now, excuse me, out of Mayo Clinic that followed a group of patients that declined treatment, and roughly a third of them got worse over time. A third stayed kind of similarly symptomatic, but a third got better. Whether they got all the way better or not is a spread. But some people appear to, in fact, get better from their leaks. And so it is possible, I think, to have a leak and then become asymptomatic. I have patients with Marfan that have been patched, do well for a couple of years, then they have a recurrence. And then sometimes if you watch them for a few weeks and you tell them to get flat for some period of time, they seem to seal again, or at least become minimally symptomatic again. I don't think that every leak has to necessarily be patched if if the symptoms are tolerable and it's not accompanied by lots of neurologic changes. And sometimes someone will reach out and they feel like they've had a return of their orthostatic headache, but it's really not too bad. And they get flat for a few days and it's 50% better. And they say, is it safe for me to keep watching this? And it seems to be. So I'm sorry. Hold on one second. Hold on. Sorry about that. I'm staying with friends as I'm giving a talk at UC Davis, and I think they didn't realize their guest room was wired for sound. So all of you got to experience a little bit of jazz. Sorry about that.
There is a follow-up question that I think is worth talking about because we did talk about we talked about seeing a neurologist and seeing somebody that really was highly specialized. Another community member is asking about prevention of
Mhm.
CSF leaks when going into surgery, whether that be for aortic surgery, which is not uncommon in our communities, or cervical spine surgery. Are there certain precautions that should be taken that this community member should be aware of?
No, I don't think we don't have really anything good in terms of prevention. I think what's those efforts really have to be geared more towards early recognition and treatment. So if you have aortic surgery and you have a lumbar drain and you're having postural headaches when you go home, like you got to be right there on the phone to your thoracic surgery team saying, "Hey, I'm having postural headaches." And the and letting them know that that's happening. Sometimes when you're in that initial post-thoracotomy, because they do a thoracotomy to get to the aorta, that's a painful surgery, and you're really on a lot of opioids at the beginning. Um, Sometimes people don't really realize they're having postural headaches for several weeks. Um, it seems, so I will say this is an area of controversy. It appears that there is a group of people that have those kind of blebs that I showed after a puncture that need to be fixed surgically that do not present initially, but appear to become symptomatic after some period of time. We have a few people where we've seen blebs like that. One was that patient. Um, I have another one who has a bleb like that. She had a post-dural puncture headache after a known accidental puncture with a labor epidural. Um, was treated, seemed to be fine for years. Then she was in a car accident, and the blood appeared to start leaking again at the time of the car accident. So this is not something that's really been published about very much. But it does appear that there are some people who appear to recover from their puncture and then can start leaking from the puncture site later. And that's really challenging because I showed you the data that most of those people are negative imaging people. They don't show up well on imaging. So it can be very challenging.
There are so many great questions in here, and I'm so sorry that we're not going to be able to get to all of them, but I am going to ask, I think, about two more. One person
Sure.
is asking if imaging is the only way to get a diagnosis of a CSF leak, and another couple of people are asking if you need to be having that imaging done when symptoms or signs are occurring, meaning for a lot of folks later in the day.
There's nobody has done a good study of patients to look at if they get imaged later in the day, are they more likely to be positive than if they were imaged at the beginning of the day? So that just hasn't been looked at, and nobody has looked similarly at the question of, if you look at people when they're less symptomatic, is that um, are they more likely to have negative imaging? We just don't know. Now, a lot of people would just tell you, no, you don't need to worry about that, but nobody's looked at that in a rigorous way. Um, I've certainly had patients tell me that they were going to try and cough and do other things to aggravate their symptoms before their imaging. I'm not sure that it helps.
Thank you.
Yeah.
Um, there's a couple questions about symptom management in here. Is there any truth to things like caffeine or salt helping to relieve some of the symptoms? And then
Uh,
related to relief or maybe to onset, actually just answer that question and then I'll ask this other question. It will be the last question that we can answer live.
well, I'm guilty of advising people with CSF leaks to take caffeine and to supplement their fluid intake and salt intake with the idea that you need salt and fluid and caffeine to make spinal fluid faster. Um, and it is certainly true that when people have high pressure, that the caffeine and extra salt and fluid really does seem to make their high pressure worse. Um, and there's some data for each of those things being somewhat helpful when people have acute post-dural puncture headaches, but nobody has looked in a rigorous way that would be scientifically reliable in people with spontaneous leaks, especially in the Marfan community, to say, like, is this really evidence-based? But some people find it helpful, and it's certainly reasonable to try. There's no reason to be killing yourself with caffeine intake and salt and fluid if you've tried it for a few days and it doesn't seem to make a difference. There's no reason you have to keep hammering away at that.
Thank you. And this last question tends to be, I don't want to say controversial, but we see this question a lot in the community about physical activity and limiting physical activity. And do you have any advice around avoiding chiropractic or yoga? You did mention earlier that you'd seen some folks have an onset of a CSF leak after yoga.
So Shevink's study looked at, again, the risk factors that were identified by people with spontaneous leaks, like what were they doing at the time their leak started? And the yoga, stretching, Pilates thing came up repeatedly in his symptoms, in his patients. And I've seen it in my patients. I think that, like, I tell my patients, if you've had a leak, like, stretching really shouldn't be a big part of your life, unless you want to, risk having that leak again. I think that it's clearly a problem for people with weak dura or compromised dura. I think that the stretching is really a problem. And it's hard. Like, I've had to tell people who are Pilates instructors, like, maybe you're going to need to find a different line of work. Um, but it's clear to me that's colored by the fact that in my own data, when we've gone back and looked at my patients, the average symptom duration among people who present to me is 8 years. Okay. And the quality of life of people with a CSF leak is similar to the quality of life of people often is similar to having advanced HIV or advanced cancer. It has devastating impact on people. And just because somebody's leak has been well treated and gone away doesn't mean that it can't come back and stay back. And so when I see somebody who's had a spontaneous leak and I'm lucky enough to really get them back to healthy, I ask myself, like, what is the danger to your future happiness of me telling you don't stretch versus the threat to your future happiness of having this leak recur and maybe not being able to fix that and having you just live that way for decades, which I think happens to a lot of people with leaks. Um, so I think, it's really hard to tell someone in the absence of great long-term prospective data, like, don't do this or don't do that. But I think when you know that among people with spontaneous leaks, lifting something heavy was a precipitant for a lot of people. Generating intra-abdominal and intrathoracic pressure was a precipitant for a lot of people. Yoga, stretching, Pilates was a precipitant for a lot of people. How do you tell someone who's recovered from a leak it's okay for you to go out and do those things? When the consequences of that can sometimes really be extraordinarily hard.
I'm talking and I was muted. Sorry. I just want to say thank you so much and echo so many of the comments in the chat here about how informative this was and how validating it was to hear from you about some of the symptoms that people are experiencing, and they're feeling empowered to go out and seek help. So thank you. You're having a direct impact on so many people. We had probably 115 people on, and we know countless others will watch the recording. I want to point out a couple of upcoming events that the foundation is hosting. We have a number of ongoing monthly support groups. One of them is actually pain management. And that may be something that if you are experiencing chronic pain related to a CSF leak or dural ectasia, which a lot of people were mentioning, you may want to check that out and just find some more support from others on a regular basis. We also have some condition specific support groups, as well as some that are geared just for teens and kids and just for parents, and some just for spouses and things like that. So take a look. Go to marfan.org/calendar, where you can see a full view of all of the different groups that we have happening, and you can register for them as well. We also have 2 in-person events happening this weekend, a Walk for Victory in Michigan and one in Boston as well. It's a great opportunity to just meet other people who are going through it and know this life and understand. It's just, there's something really, really special about that. Next week, we have a webinar on navigating government SSDI benefits. That's free. It's being hosted by a legal firm, and they are experts. So come, ask your questions, learn, get prepared. And then another really incredible opportunity for you to gather with others in person is at the Marfan Foundation's 40th conference in July in Atlanta. Registration is still open, and tomorrow is the last day to book a hotel room at the foundation's reduced rate. And then I also really want to encourage you to take a few moments to complete our survey at marfan.org/survey. We'll send this out in an email so that you can go ahead and do that on your own time, or you can click on the link that I put in the chat or copy the link in the chat. It's really, really helpful for us. The reason we're able to have this webinar tonight was from community feedback from you guys. We want to know what you are interested in learning and how this is helpful to you so that we can plan these educational programs and answer the questions that you have. So I hope you will all again join me in thanking Dr. Carroll for being so generous with his time and knowledge and expertise today, for empowering so many of us to go ahead and get some more answers. We are so, so appreciative.
And I appreciate you guys spending your time organizing and working towards making the lives of patients with Marfan better. Just thank you for your efforts too.
Thank you so much.
Thank you,
All
Dr.
right.
Carroll. We
Bye,
appreciate
guys.
everything tonight. Great comments, guys.